we're gonna get started. Thanks for everyone in the room for coming, and thank you everyone online. It looks like we're at over 25 people so far online. We still have some people shuffling in the room, but we'll get moving. So just some housekeeping things. Today, our speaker, who I will introduce more in depth in a moment, is Helen Lamont, the Director of the Division of Disability and Aging Policy at U.S. Department of Health and Human Services in the Assistant Secretary of Planning for the United States. Her title of the talk is Advancing Federal Dementia Policy through the National Plan to Address Alzheimer's Disease. If I can make the slides go forward, there we go. Questions, there will be Q&A after the presentation. If you're online, please use the Q&A feature. Questions will be asked on your behalf. Feel free online to enter questions as we go, but we will not get to them until the end. Closed captioning is provided in Zoom. The seminar is being recorded. And if you're experiencing technical difficulties, please email jhcochlearcenter@jhu.edu. Some future upcoming seminars, we have Sumit Dar from Northwestern University, the chair of their audiology program, speaking January 23rd. February 27th, we have our own Adam Spira from Bloomberg School of Public Health. And then March 27th, we have Jeanette Mahoney from, actually it says Albert Einstein College of Medicine, and she probably still has an appointment there, but she is now at SUNY, Stony Brook, a international expert in multisensory integration. And Cochlear Center Research Day is Friday, April 25th from 9 to 4 p.m. For those of you who have been in the past, you know we'll do several talks. The Research Day keynote is Laura Nyblade, from a PhD from RTI International. And we will have several internal talks of our details, and we have lunch if you come in person. It's a nice day to mingle. And we also do a wonderful poster session. So today, super excited. Full disclosure, I work with Dr. Lamont. She's my supervisor in a health aging policy fellowship, so I have to be super nice to her now. And she's a wonderful person personally, but she also is extremely accomplished. So what we're about to say is not everything. Helen Lamont is the director of the Division of Disability and Aging Policy, where she manages a team of professional staff that conduct policy analysis, research, and evaluation related to disability, aging, and long-term care issues and programs in the United States. Helen also leads the implementation of the National Alzheimer's Project Act, coordinating both the Advisory Council on Alzheimer's Research, Care, and Services, as well as the interagency group that writes the annual National Plan to Address Alzheimer's Disease. And she's been involved with this since its foundation several years ago. Helen also leads a portfolio of research in dementia, including a project to examine use of inpatient psychiatric facilities by people with dementia. She works on family and informal caregiving, as well as elder justice and adult maltreatment. Helen's worked across the Department of Health and Human Services on disability data issues and has a current project to explore feasibility of using an internet panel study to collect data on disability. She joined ASPE, Assistant Secretary of Planning for the United States office, in 2007 and has a PhD in aging studies from the University of South Florida. We have several colleagues at the center from the University of South Florida. Some of them might be on, so go Bulls. Bulls, yeah, Bulls. Near Tampa, that's what I know. And a BS in Human Development from Duke University. So with that, I will hand over the mic to Dr. Lamont. Please welcome her, and Mindy, I think will change, yeah.
Either one, click or that's right.
Or the.
Okay. All right. Thanks, Nick. Hi, everyone. Thank you so much for having me today. My name is Helen Lamont. I was a graduate student at USF, and we did a very similar seminar series back in the day. Hi, Kate. And how we always started ours was to talk about how we got into aging. And at that point, it's really amazing to watch how the world has changed since then. At that point, none of our seminar speakers had started in the world of aging. Now I think there are people that have entire careers in the world of aging. So I'll just give you a little bit of background about myself, especially because we have some students here today. So I did my undergraduate at Duke, and it was my work study job. Do they still have work study jobs? Okay, my work study job was photocopying for the Center on Aging. And I happened to be there like photocopying the Pepper Grant. The president of GSA was Harvey Cohen, who was there at the time, and photocopy. Gerda Fillenbaum, who is foundational researcher on IADLs, was in the copy room with me, and so I was surrounded by these luminaries in aging, and at some point was looking for an internship and learned about this aging policy internship where you could go anywhere you wanted in the United States and work on aging policy issues. So I got a placement in New York City at a advocacy group called the Center for Senior Centers and Services, CSCS, which is still around but has a different name. And through that process, sort of fell in love with aging and aging policy, and then using information and research to inform aging policy. The fall of my senior year, so now you'll know how old I am, 9/11 happened. And so there were no job opportunities to be had. And so I decided I wanted to go to graduate school and went to school for gerontology, which was very new at the time. I went to University of South Florida, spent a few years growing up a little bit, but doing policy research. And then the last key thing that I will say is make sure you publish your dissertation. My dissertation was on what we now call social determinants of health and racial and ethnic health disparities in older adults in Florida. And I had different components of the environment, the social environment, the built environment, the healthcare environment. These are all things that we're talking about now. And decades later, it's devastating to me in some ways that work that I did isn't all called at that point, the ZIAC, determinants of health. Or something like that. But the wonderful thing about working in government is that you don't have an agenda. I'm just glad that the work that was done continues to get done, and that there's a recognition of the impact of all these different variables on people's health and well-being. So sorry for the long story. And then my other apology to start with is that I'm going to use a lot of acronyms. And the government is alphabet soup. You can probably try to Google what I'm saying and you will not get it, because I tried that when I started working in the government. So if you want me to clarify what I'm talking about, let me know. And some are true acronyms and some are just initials, so apologies. So HHS, which has gotten a lot of attention the last week, the Department of Health and Human Services is, I think the operating budget is big as it would be the fourth largest country's operating budget in the world. CMS is part of HHS, NIH is part of HHS, FDA, the Health Resources and Services Administration, the Administration for Community Living, all these others in the middle. And then there is the Office of the Secretary, which kind of sits above everyone else, all those other operating divisions. We're called staff divisions, and we work on cross-departmental things. So the Assistant Secretary for Financial Resources, or ASFR, is our budget office. The Assistant Secretary for Health works on health, that's also been in the news. ASL works on legislation, and I'm in ASPE, the Office of the Assistant Secretary for Planning and Evaluation. And if you think back to when HHS or any of the federal departments were first set up, these were actual singular people that served in these roles. And now as the government has grown, these are full offices staffed up to support the mission of HHS. So ASPE we describe as a think tank within the Office of the Secretary. And our main audience is the Secretary of HHS and policy decision makers. We provide analysis and advice on policy options, things that are coming up. We lead special initiatives like the one I'll describe today and coordinate the department's evaluation, research, and demonstration activities. We work on strategic planning. So in addition to the actual strategic plan that I'm going to describe, we have a strategic planning office that provides support for all agencies that want to do strategic planning. We review legislative proposals from the agencies. There's actually a process by which legislative change are put forward through the president's budget that we play a role on, as well as providing technical assistance on legislation that's active on the Hill. And then we review regulations with a policy lens. In order to do all this, we conduct research. So there's pretty much at least one person in ASPE who knows or is responsible for the entire portfolio or one section of the entire HHS portfolio. So there is somebody who knows what FDA is doing or how FDA is working on tobacco products, for example. So we're charged with sort of staying on top of what the agencies are doing and then looking to future trends in the area. So what's happening in the private sector to some extent that would influence the federal government, what's happening in academic research literature, what's on the horizon, and what do we need to know about to make decisions. We do conduct policy analyses, which are sometimes very quantitative, often very qualitative, and then look at the costs and benefits of policy alternatives. Again, sometimes that is a very quantitative activity, and other times it's more qualitative to say, if you do this, you need to think about all these other factors around it. So it's a really fun place to work. We aren't constrained to one agency's grant-making program or operational program, so we get to think really broadly about things that affect HHS and its programs. So we get to be very creative in our thinking. And my office is the Office of Behavioral Health, Disability, and Aging Policy, call ourselves BDAP. And we focus on those populations. So we focus on policies that affect people with behavioral health conditions, including substance use disorders and mental health conditions, people with disabilities, and older adults. And we are focusing on the policies and the programs that affect those populations across the board and are focusing on independence, health, well-being. So this is a list of some of the topics that we work on, but as I mentioned, anything that's going to affect those populations, we're either working on or thinking about. So HHS doesn't have a lot of policy around transportation, but anyone who works in aging or disability knows that transportation is a big issue for all of our programs. So we have somebody who knows what's happening in transportation policy, just because it's such an important part of the overall life of people with disabilities and older adults. So I came to ASPE in 2007, right out of graduate school. I was an analyst there for a little while, and then I got maybe like the most government job ever. I was the acting special assistant for the assistant secretary, which is like a fancy way of saying, you know, someone's assistant. And it was Sherry Gleed, who Nick reached out to recently. And so she was sitting in the front office, which is government speak for, you know, in an important suite. And so I had a seat in the front office and was sitting there. And I can distinctly remember where I was when Don Molds, who was our principal deputy assistant secretary, came into the building or into the suite and said, "Helen, I'm going to a meeting at the White House on Alzheimer's. I need you to come because you work on aging." And I was like, okay, like, oh, I'll go to the White House, of course. Totally happy to go. And we were brought together by the Domestic Policy Council. It was actually, what's Carol's last name? Anyway, she's now the director of HRSA. She was the DPC lead for much of HHS, and a bunch of Alzheimer's advocates had reached out to her demanding a meeting because the National Alzheimer's Project Act had passed and nothing had happened with it. And so in the car on the way back, they turned to me and said, "Helen, guess what? We'd really like for you to take this on." And I did. And the rest is sort of history. So backing up a little bit, the National Alzheimer's Project Act, or NAPA, we'll use that acronym a lot because it's a great one, is this very simple 3 to 4 page piece of legislation that requires essentially HHS to create and maintain a national plan to overcome Alzheimer's disease. And then in order to do that, to create an advisory council to review and comment on what the government is doing and to make recommendations on what could be done better. And I think I get more details on the advisory council But those are two separate but related activities that we work on. The advisory the legislation says Alzheimer's research, care, and services, and so we've kept that throughout, and you'll see that continue to work. So when you are a young entrepreneurial new person in the government and someone says we're going to do this, the first thing you have to do is see what are we already doing. Very interestingly, at the time, there's only one program, I believe, in the entire federal government that just was on Alzheimer's, and it was a DOJ program to find missing people with Alzheimer's disease. By and large, everything else programmatically that we were doing was for a broader population. So in 2011, we're working on getting this advisory council set up, and we decided let's get the feds together and quickly inventory everything that we are doing in these three buckets: research, clinical care, long-term services, and supports. And we were so lucky that we had such quick buy-in from our federal colleagues, all got together, we literally wrote an inventory during that summer, and then you'll see our timeline. So this all came together in April. In September, on September 27th, we had our first advisory council meeting, which was lightning speed. And at that meeting, we presented our inventory. This is everything the federal government is doing on Alzheimer's disease, or in the case of something like Medicare and Medicaid for people with Alzheimer's disease. So we had to, cast a wide net. We then were the statutorial deadline for the national plan that was required, I believe, was 1 year from enactment, which would have been January 4th, but we got started late. And so in order to keep things moving, we released a framework for the national plan, and that was what will become our goals in January. We got buy-in from the administration around that time. In April, the advisory council made recommendations, and then on May 15th, we released the first national plan to address Alzheimer's disease. So while it was not within that 1 year, it was lightning speed in government time. And we were so excited to have Secretary Sebelius release the national plan at the first International Research Summit at NIH. This was the first time NIH was bringing together a very large group of researchers to tell them what the priorities should be for Alzheimer's research. That date actually is what drove it, and Secretary Sebelius announced it then. We also, a little bit of context, that was during a time called sequestration, which required Congress to make certain budget cuts. And then if they didn't, they were like mandatory across the board cuts. So it was a really, really, really lean budget time. However, the department was super committed to this work. The Domestic Policy Council was committed to this work, and Francis Collins was committed to this work. So during that spring and at that release, we were able to announce a commitment of $100 million, which was not insignificant at the time, to new $80 million for new research projects, a provider education grant program that was $15,000, and then a $5 million public awareness campaign where we actually had television ads. And Francis Collins was there. It was Secretary Sebelius's birthday, so fun fact, he sang happy birthday to her at the release of the plan. I will never forget that. And this is the national plan that we came up with. We printed it the first time and have never printed it since then, but these are our 5 goals. To prevent and effectively treat Alzheimer's disease by 2025, that's the most popular goal, of course. To optimize care quality and efficiency, that one primarily focuses on clinical care, but crosses into long-term services and supports. To expand supports for people with Alzheimer's disease and their families. To enhance public awareness and engagement. And then, of course, because this was coming out of an evaluation shop, to track progress and drive improvement. When we wrote the national plan, as I said, the first goal got the most attention, but what we really tried to do was to balance our work on research and treatments with the care needed by people with the disease and their families right away. So we took a really balanced approach to what we were doing and what we could do, because we felt like both of those were important core values to be addressing. The goals obviously are aspirational and long-term, and under each of them there are strategies to achieve those goals. and then immediate action steps that describe what we are doing. And I say are because it's still active. We're still updating it annually. We had an implementation timeline, which we have since deleted actually because it was overwhelming. And then we report on our progress at our advisory council meetings, and this says biannual, but now it's almost every quarterly meeting. And as I mentioned, it's a living document. It's updated annually, which means that our 2024 update is going to be out in the next few weeks. So it's not like we put it on a shelf. It's literally an active document that people go to on a regular basis and can see where we are on even specific projects. So you might, well, Kate knows this because she works in the government, but it might be like, oh, great, you did this. It was actually a tremendous amount of work and a tremendous accomplishment. And I would say there are a few efforts that have replicated that because the conditions weren't right. So Alzheimer's and dementia are very unique because of the very strong bipartisan political support for this topic across the board, very consistently positive feedback and input from supporters on both sides of the aisle. The administration at that point's commitment and support to this work to some of the highest levels of the agencies. It was a complement to the Affordable Care Act, which had passed earlier in the administration, and this was a way to build off of some of that work. It was a pressing timeline. I do ... because actually my second son was born May 17th, 2012. So I was out to here pregnant. And when we had our first meeting of the advisory council in September of 2011, everyone's like, well, when's the plan coming out? Well, by mid-May, because I knew that I had a timeline. And we had, I was committed to achieving that, and we met that deadline. I will say since then, I don't know if it's realistic. And when subsequent efforts have been underway, I feel like it was actually helpful to have that timeline, as stressful as it was, because subsequent efforts, you can get stuck in making it perfect and getting lots of input. And we knew we had a very firm timeline. And then finally, we had a very supportive community of advocates. I won't say they didn't push us to do more, but no matter what we did in some ways was going to be a win politically and also in the press. And that does make a difference when you're doing government work. Everyone likes to do something that's going to be well received by the public. And we were no exception to that. So we continue to do all of this work. I'll go kind of quickly through this. We have quarterly meetings where we have our subcommittees talk about these different topics that we're working on. And then they make recommendations to the federal government. We take the recommendations and we use those to inform our federal plan. So the advisory council I mentioned before is kind of unique. It includes both federal government members and non-federal government members. And there's lots of advisory councils across the government, like the President's Council on Physical Fitness. NIA has I think it's the Advisory Council on Aging. And generally they're composed just of public members who provide input and recommendations and consensus to some federal authority. Ours has very specific positions on it, which I won't read through here, but with a variety of different perspectives, which is very, very helpful. And then in addition, a unique part of NAPA is that we also have representatives of the federal government, primarily HHS, but also the VA, the Department of Defense, and the National Science Foundation. So it's a little bit clunky because the federal government generally doesn't make recommendations to itself in a public forum. But what we've sort of worked out is that our federal partners provide technical assistance. So say one of our advisory council members says, oh, I really think that people should get hearing devices so that they don't get dementia. And then our feds say, thank you for that recommendation. Unfortunately, covering hearing devices would require legislative change. And so that helps our advisory council craft their recommendations to the right people. And unfortunately, there are a lot of statutory limitations. So there are a lot of recommendations to Congress. Our meetings are public. I'll do a little plug for them at the end. They're in person generally, and now obviously hybrid, and then they're all open to the public. excuse me, they're all web streamed. That's what I meant to say. And most of the substantive work happens in our subcommittees, which meet monthly. They're organized by the subcommittee chair, and those are parallel to the federal work group. So we have research, clinical care, long-term services, and supports. They plan a panel to inform their work, and then they craft recommendations that they present at the July meeting. These recommendations are made to the Secretary of HHS and also to Congress. We're kind of lucky that we get Congress there because there's so many recommendations that are to them. They're often very aspirational. This is the link to get them. And then they're generally adopted in July or August at our meetings. They're shared with the Secretary of HHS and congressional leaders, and they inform the activities that are reflected in the national plan update annually. And a little bit of Wizard of Oz behind the curtain. It's not the secretary per se that is blessing what has been recommended, like, yes, we will go do recommendation number 6B. It's really the federal staff and leaders who are hearing these recommendations, hearing the concepts, are learning about the areas that folks want to focus on and where the gaps are, and are taking those back to their agencies and their agency leadership to implement as action steps through the national plan. So part of the reason NAP has been successful is because of the feds, and my federal colleagues really deserve a huge round of applause for everything that they've done. They are a really, really committed group of people. Dr. Hodas from NIA has been participating since the very, very beginning. Sherry Ling from CMS has been a huge advocate for our work. Joan Weiss over at HRSA, Aaron Long at ACL, and even before her, Jean Tilley. So we've had a group of feds who have been working on this for a very long time and who work together really well on this. It's nice because they can all be engaged. If we were just focused on research, it would only be the NIH show, really. But there are all parts of what we do that affect people with dementia. Oh, that's light. So we all have a role to play in this. And then we provide this technical assistance on these recommendations, and that's built a really collegial environment. I described how we take the recommendations back to the agencies, and then those topics are advanced. And sometimes you'll notice recommendations come up year after year after year. A good one is that NIH should have a national summit on dementia care. I believe that was a recommendation for 3 years before it actually happened, but it was realized. And so sometimes there are ideas that need to percolate and need to be heard, and then they do eventually get implemented. So never give up. And then this has been a great forum for quickly turning research into practice because NIH is working so close in partnership with these agencies that are delivering programs on the ground. And then finally, I would just say healthy skepticism, but commitment to issues. If we get a crazy bananas recommendation, okay, thank you. There's always a, well, wait, what, but let's think about perspective on things. But at the end of the day, everybody who's working on this in the federal government is really committed to advancing good quality care and a cure eventually for people with dementia. And so the work continues to move forward because of both of those perspectives. So a few of our innovations that we've had that sort of are a result of this federal partnership are this program, I forget the name of it, but very simple, extremely innovative. So what we would hear from researchers was, gosh, I have all these people showing up to my clinical trial and they need support, or their caregiver needs support, and I don't know what to do. And then we heard that they needed more clinical trial enrollees. And you have the aging network out in the community providing supports with resources for people with dementia and their caregivers. And so ACL and NIH partnered to just tell each other's networks about themselves. So we told the researchers, like, hey, if you've got somebody who needs some more support, this is the aging network. It's available across the country. These are the programs that they provide. And then we told the aging network about how they can connect their clients to research. And if someone comes in and they're getting services and they're like, gosh, but I would really love a cure for Alzheimer's, hey, there's a research center down the street that you can go to. So this was a very simple innovative, though, approach to this and really shows the partnership between our agencies. And we've taken things like, and these two are both, happen to both be IHS examples, but we've taken concepts from public health, like the Healthy Brain Initiative roadmap, and applied it in Indian country and sort of cross-fertilized. And then the REACH program, which is a demonstrated caregiver support program, it was tailored to the VA, carried out in the VA. And then because the VA is so similar operationally to IHS took the REACH VA and applied it in their tribal communities. So really a lot of people learning from what's working with each other, bringing it back to their agencies and figuring out how they can apply this work. I can go slowly or quickly through this. So I have slides that go through some more specific accomplishments, but high level, our progress from 2012 to 2020. And I tried to do real progress, not just, operational things. So now we have 3 tri-annual summits on research that inform all of the work that we're doing. But in terms of effects, we've gone from 10 genes when we started to more than 70 genes that are associated with Alzheimer's disease or other dementias. We know a lot more about the prevalence and co-occurring of different dementia pathologies. So it turns out, I believe it's only 7% of people who die with dementia only have Alzheimer's disease pathology in their brains. And if you think about that for a moment, that makes a huge difference in how you're targeting treatments, what treatments you're focusing on, and what you would expect the effect to be of any treatment that just targets Alzheimer's disease, for example. We now have blood tests that can tell us when we started, it was at autopsy really, that was the only opportunity to find out if someone actually had Alzheimer's disease. We now have blood tests. There's huge data sharing advancements, cloud computing before it was a real thing. There's infrastructure for clinical trials and clinical trial diversity. And then, as I mentioned, this understanding of these various mixed dementias is a big area of focus. We've also at the same time expanded programs to serve people with dementia, notably the ACL Alzheimer's disease program. This was in 2022, our 2022 data, I believe, that they had served over 35,000 people with 2.3 million direct service hours. And if you knew how low their budget was, you'd be even more impressed by the work that they were able to do. And then IHS is a real example where they had nothing focused on dementia, and just from being part of this work, they went back and were like, we need to do this, we need to get this into our programs. HRSA's geriatric workforce enhancement programs have continued to train people on the special needs of people with dementia in a variety of different disciplines, which is a major advancement because people like dentists need to know what to do when they have somebody with dementia. And they've also developed a curriculum on dementia care. So before we started our work, there was no unified singular curriculum on dementia care. Again, it seemed simple, but it was a huge need. And then on the public health front, there was already a Healthy Brain Initiative. It's actually coming up on its 20th anniversary this spring. But there were advances in the roadmaps for brain health, which are basically playbooks for public health departments to pick up and say, what can I do to advance care for older adults, especially related to brain health? And then in 2018, the BOLD Infrastructure for Alzheimer's Act, which really codified this public health approach to healthy brains, dementia risk reduction, caregiving, and the unequal impacts of dementia on different populations, was passed and enacted, and that has been a huge area of focus for public health since then. These are really detailed. I won't go through all these because they're kind of boring. Not boring, but it would just be listing them. You can read them later. Probably, and especially if you're in an academic setting, the area that gets the most interest and the biggest accomplishment, if you will, has been the increases in the Alzheimer's budget at NIH. They kept the numbers a little bit differently, but when we started our work, it was $450 million. And I didn't continue this to FY23, but by 2020, it was a 5-fold increase. I believe it's an 8-fold increase since then. We were under sequestration in 2012 and 2013, so that's why those numbers are very, very low, and then they really started to take off. And while I would love to take credit for that, I actually cannot take any credit at all, and nor can NAPA. I think this is important. We've seen NAPA be replicated legislatively multiple times now, and people say, oh, well, NAPA happened. Why don't we have a fivefold increase in research on X after the equivalent NAPA legislation passed for them? And the secret is that it's not NAPA that is leading to this. It's something called the bypass budget. So when NIH committed to the first goal of the plan to prevent and effectively treat Alzheimer's disease by 2025, you've got some very committed scientists at NIH who are thoughtful and pragmatic and are like, okay, how could we actually get there? Like, they meant it when they committed to that. So they set up a timeline of milestones. We would have to achieve this by this date, this by this date, this by this date and I think this is how they decided to commit to 2025 to get to this goal. And so they have a milestone document. It used to just be a Gantt chart. Now it's much more complicated than that. And it's a framework with specific steps and success criteria towards achieving primarily that first goal of the national plan. They've now expanded it to focus on a variety of different areas. So in our very first meetings, it got a little contentious because the advocates and our advisory council members would say, you've committed to this goal of 2025. You have $450 million in funding, which at the time was like a drop in the bucket compared to cancer or HIV. How are you ever possibly going to achieve the 2025 goal? And as I mentioned before, the federal government doesn't like to tell the federal government what to do, especially not publicly. There's also something called the Hatch Act, whereby a federal employee cannot advocate for legislation, for appropriations, for a political person. And you can't, like, I couldn't wear my work ID and go door to door and tell people who to vote for. So it covers a variety of things. So there's a lot of frustration that the federal experts who had committed to this goal were unable to say that they needed more research funding to achieve the 2025 goal, because for the federal government, the president's budget is what we believe we need. So every year, OMB puts out what's called the president's budget. Generally, it's in January, it's pushed a little bit, and the president's budget has what the president and the administration believe is needed for each agency in the federal government to carry out its work. And so as a federal employee, a lot of work goes into that budget. And as a federal employee, the president's budget represents what the government believes we need for each program. So the advocates felt like that was not what the government experts actually thought was needed. And they found this interesting way to go around that whole process called a professional judgment budget or bypass budget. And so through that legislation, NIH staff review the research implementation milestones, and they consider what additional resources they need to pursue new scientific opportunities in the areas of the milestones and then any evolving areas. And then they think, again, they're very detail oriented, how much they have and how much they need and what that additional gap is. It's always been an additional amount of money they need. And then they present that to Congress, and it doesn't get modified through the traditional federal budget process. So in July, Dr. Hodes presented the FY25 professional judgment budget, and that was an additional $318 million in support for new research that would take the overall resources for Alzheimer's disease to $4.07 billion. So quite a large increase since where we started. And he presents that annually at our July or August advisory council meeting. And it has been extremely, extremely effective. I believe this past year was the only year that additional bypass budget amount was not enacted. This year, I believe it was only $100 million, and they had estimated that they needed more than that. But it gives the advocacy community a number to take to the Hill, to these bipartisan champions, to say, hey, you want to eradicate Alzheimer's disease by 2025? We want to eradicate Alzheimer's disease by 2025. This is how much more money we need. So from a public policy perspective, it is fascinating. And the only two diseases that have bypass budgets are Alzheimer's disease and cancer. So all this is going on. It's this probably gets boring after a little while, but let me tell you, no. So in 2020, I'm sitting at home, working away, and I get invited to this meeting to start to begin to talk about preventing dementia. What can we do? We know about all these risk factors. So a couple of studies had read out in 2020 that showed that, and depends on if you look at Lancet or some ARC work or NIH work, showed that if you address some health behaviors in older adults or in midlife, you could reduce your risk of dementia by 60%. And we very quickly moved to start to think about this. So this was the big area of focus during 2020. We quickly formed an advisory council subcommittee on this. They made a recommendation that HHS set a goal and on risk reduction and make this a permanent part of NAPA. So in 2021, they made the recommendation. In fall of 2021, we contemplated this. And just to give it all away, in December 26th, I believe was the date. It was after Christmas, but before the end of the year, we rolled out the 2021 update, and it had a new 6th goal to accelerate action to promote healthy aging and reduce risk. So we decided to focus on healthy aging. We focused on risk reduction rather than prevention, because it's really a public health approach. We're not saying that if you do these activities, you're definitely not going to get dementia. You still may, but at an overall population level, if we address these modifiable risk factors, we should see a reduction in the prevalence of dementia. And it built off of the infrastructure we had already done. And it also built off of the broad infrastructure we already have in terms of the aging network, public health, supports for people out in the community. And it focused a lot on inequities in dementia, which is a huge challenge, an opportunity to lower the prevalence of dementia, frankly, and was obviously a focus of this administration. And that went all the way up to Secretary Becerra, and he appeared on the Today Show to talk about it. Oh, no, it wasn't the Today Show. I'm sorry. He appeared on TV to talk about it. So that was exciting. So I'm going to go quickly because I can see that we're getting late. So this goes through our strategies for goal 6. We want to advance research and then translate research findings into practice. We're going to accelerate the public health work that we have been doing, expand interventions that we know work, because there are interventions out there. As I mentioned, address inequities, and then advance public engagement. Again, sort of parallel to the overall plan. A little plug, because I know this group is interested in hearing loss, and the timing kind of worked out for this, that FDA had just, established the over-the-counter regulatory category for hearing aids to make hearing aids more available, and because we know it was relevant to risk reduction for dementia, we really highlighted it here. And since then, our advisory council has this fourth subcommittee that continues to make recommendations, and I wanted to highlight that they want existing insurance and health plans to cover hearing aids, because we know that that's a risk factor for dementia, and that should continue to work. So the work continues to advance things that can address risk factors for Alzheimer's disease and related dementias. I'm going to speed by. God, I thought I was going to be tired of talking by now. So real quick, we've seen, so all of this is building up. Not a lot of studies had read out by 2020, but starting in 2021, we really started to see our progress take off. So the very controversial Aduhelm was approved through the accelerated process at FDA in 2021. And then following that, we saw in 2023 lecanemab being approved, and then donanemab was approved this year. So those are the first disease-modifying treatments for Alzheimer's disease. IHS created this grant program, so they've sort of really made something out of peanuts at the beginning. They had no money, but we're continuing to do this work and finally got a congressional appropriation to expand this work to Indian country. CDC held a dementia risk reduction summit, so building research on risk reduction. And then very excitingly at our July 2023 NAPA meeting, CMS announced the GUIDE model, which I'll get into in a minute. And then in this year, GUIDE has started to operate already in a couple of sites, and CMS has physician fee schedule, which means they will pay for services to do caregiver training and principal illness navigation services, so care coordination. So some of these sort of foundational things that we've been talking about for years, caregivers need support, they need to know what to do. And people with dementia are complex, are being paid for through our healthcare system. So that was an exciting development. The GUIDE model, which if you work in the space, you will start to hear about, and if you work in aging at all, you will probably hear about, because I feel like it's the first time that we are really truly understanding that people with dementia and with complex health conditions and older adults need help coordinating their care, managing their care, and their caregivers need support. So both parts of it. It's not just enough to coordinate their care, keep them going in the health system, but bringing in that essential role of the caregiver and supporting the caregiver and supporting it with a little tiny respite benefit in addition. So the caregivers actually get a break. CMMI is testing this model, and it's going to be, I believe, an 8-year, maybe 7 years with the evaluation time. So it's going to be a couple of years till this is built out. But this, in many ways, comes out of all of the NAPA work before it. So it builds off of what we know in terms of evidence-based interventions. It builds off the complexity of managing people with Alzheimer's disease, the caregiver support pieces. And this is one where I think I can say fairly that my federal colleagues behind the scenes were really pushing, like, this is what we need to do. We know that these components work. We know that if we can help address the caregiver needs, we can have better outcomes. And it did eventually lead to this GUIDE model. Gloss over that. So where are we now? Well, we do have some disease modifying therapies, and they're really going to transform the way that we provide care, diagnose people. We need to figure out, because some of them don't have Alzheimer's disease, how to differentially diagnose. That was in the original plan. It continues to be a challenge. We don't have easy biomarkers for a lot of the other dementias. And that is a huge area, a huge gap. So we really need to make some advancements in that area. How will we address people with multiple pathologies, both from a systems level perspective and from a treatment development perspective? This GUIDE idea of providing care for the symptoms of Alzheimer's disease or dementia, which might be need for care coordination, it might be caregiver support, it might be training, how to provide this coordinated care and how to do this in addition to just the GUIDE model. We've got the components out in the community, so how can we start to provide that care? Workforce is a major issue, both from a clinical perspective, less so from an NIH researcher's perspective now, but from a clinical perspective, and then from the long-term services and supports perspective, and then risk reduction. There are good and bad sides to risk being higher if it develops over the course of a lifetime. You know, where do you start if somebody's been exposed to air pollution for 70 years? What do you do about people having less education when they were kids, when they're in their 80s? So figuring out where are the most actionable areas on risk reduction and where should the government begin to focus? Why is NAPA working? I already touched on the committed federal staff. Again, we're looking across the board at all parts of Alzheimer's disease. We're focusing on research and living with Alzheimer's disease, and then who's going to get it next. And I would add to that now, thinking about what we can do right now to help people reduce the chance that they get Alzheimer's disease. We continue, and it has definitely improved, to have a collaborative effort with the advocates and the stakeholders in the community. They keep pushing the federal government. We say, okay, but we do, move forward, and it has been a very effective partnership. We've had consistency in our federal staff who have participated. Again, Dr. Hodes comes to every meeting. Sherry Lynn comes to every meeting, and so we see high-level people making the time to prioritize this. And as a result, I think the unique needs of people with dementia are sort of recognized across every program that we do, cognitive impairment. Any program that the federal government does, there's now a discussion about what does this mean for people with cognitive impairment. So that's really exciting. And this was the slide I meant to move and didn't. So why focus on dementia? And this was a big debate when we first started NAPA, because we didn't want it to be what we called the Disease of the Month Club, or what more senior people called it then, because I was brand new. So why would you focus on dementia? And the reason that it works is because people with dementia are like the most vulnerable of the most vulnerable. So it's hard to identify them and to get them diagnosed. People don't want this condition. They don't want to tell someone they have this condition. They often have many, many chronic diseases, but dementia affects the management of those diseases. And so much of our health system puts the onus on the individual to manage those chronic diseases. They're high users of healthcare in all settings. I believe I heard a statistic last week from our health policy colleagues that 30% of the top 1% of healthcare spenders have dementia. So it is a huge, huge proportion of the high costers. And we know people with dementia get hospice at a higher rate. So it may not even be at the end of life, but at some point during their trajectory, they're using a ton of healthcare. And they probably are not getting the best outcomes from that care. And then we know there's an unequal burden on different groups of people when it comes to dementia, those with lower education, certain racial and ethnic groups, and then everybody with Down syndrome. And that's been a huge area of focus for our work too. And then back in the day, my office had long-term care in our title. We still work on it, it's just not our title. And so for our office, this is really the core of the long-term care population. These are people who need care for many, many years. They need a lot of care because often they need supervision. They get care in all settings. You're not going to get rid of nursing homes because sometimes people with dementia need 24-hour round-the-clock care in a nursing setting. The huge impact this has on family caregivers as well as staff. The training that we hear the direct care workers need is always, I need training for people with dementia and how to better serve them. And then the unique challenges of person-centered planning and advanced care planning. So in aging, we say, oh yes, you need to plan to get old, you need to plan for long-term care needs. But with people with dementia, there's a limited window. So you really, really have to do these things. And then on the research front, there's so much still to this day unknown about the diseases that lead to dementia. It relates to all different biological systems in the body and the brain. And so I think there's still a lot more work to be done, but it's a really challenging intellectual question of how you can advance dementia research. So real quick, on October 1st, this is not an actual picture of it happening. Full disclosure, President Biden signed NAPA reauthorization into law, which will extend this work through 2025. So that's exciting. And then what we're going to do is take a fresh look at our goals. Do they still make sense? Do we use Alzheimer's disease? Do we use different terminology? Do we set a year because the year galvanized people so much? Or do we take a different approach? Our national plan is 180 pages, and I have set a personal goal of not having a national plan that's 180 pages into the future. Do we streamline? A lot of federal activities focus just on one thing, and we've really taken on the whole pie of things related to dementia. Do we keep that approach? And then one gap is engaging the private sector. So there's a lot happening, as you all know, ARP, Milken. I mean, lots of people are working on Alzheimer's now, and how do we reflect that back in the work that we're doing? We're involved with it, but our national plan really is just reporting what the federal government's doing. So real quick, if you want to get involved, I can share information on our listserv. Our meetings are live streamed. Our next one is January 13th. And we will be soliciting nominations for new members in the spring. So if you get on the listserv, we can share that request. We need unique perspectives, different places in the country. We have to have geographic diversity in our representation. And then with NAPA reauthorization, we now have a codified spot for a person living with dementia, a researcher who has successfully recruited diverse populations, and someone with an enhanced lifetime risk of dementia. So in addition to our other slots, we have 3 more slots on the advisory council, and I would love to get more input from people as time goes on. So I'll have 2 minutes for questions. Thank you. Sorry to talk so much.